Bismillahirrahmanirrahim. My affectionate students, I congratulate you in my second in my second lecture on topics analgesics. In here, I will discuss about morphine and which are more important clinically and exam orient and for examination, especially for viva examination. This point will be given more emphasis. Now, morphine produces analgesic effect. Is it a specific mechanism or non-specific mechanism? Answer will be by specific mechanism. Why? Because it binds with specific receptors. Morphine has got its own receptor like mu, kappa, delta, sigma. This drug binds with its own receptor and produce their drug-receiver interaction occurs, produce a complex, and that complex initiates a series of events, ultimately produces effect. So, if an analgesic effect of morphine or morphine-like drugs or opioid groups is by specific or receptor mechanism and selective mechanism, not non-specific, non-receptor or non-selective mechanism. Now, routes of morphine. It cannot be given orally. Morphine, not only morphine but also pethidine, it cannot be given orally. Because it undergoes hepatic first-pass metabolism. Once upon a time, morphine tablets were available, but it is no longer available now because these drugs undergoes extensive hepatic first-pass metabolism or perisystemic elimination. That's why drugs should be given by injection route, IM as well as IV. But in case of patient of shock, subcutaneous route should be avoided. ALVF, in this situation, this should be the subcutaneous route should be avoided because there may be peripheral vasoconstriction, so drug absorption will be delayed. So IM is the preferred route and IV route. It can be given sublingually. Buprenorphine is one of the member of this group, can be given sublingually. Also intranasally, there is one drug that is butorphanol. Butorphanol, it is moderately powerful analgesic. It can be given by intranasal route. Also this drug can be used as suppositories and in lower rectum, because in lower rectum drug drains to systemic circulation, avoiding portal system. So these are the routes by which morphine can be introduced into the body. Now this drug undergoes metabolism in liver and it is glucuronide conjugation. The conjugation reaction, glucuronide conjugation occurs. Morphine excreted through metabolite of morphine excreted through urinary tract, through urine. Also this drug is secreted into the stomach, and through it also eliminated through the GIT, but the main route is through intestine. Now morphine, I mentioned earlier that it is used in severe visceral pain, severe colicky pain. Sometimes it may be asked by the examiner that toothache, it is also very severe pain. Toothache, really severe pain. So in this situation, should we give morphine? Answer will be no. Why? Because this pain, tooth pain or body ache, muscle pain, myalgia, these are dysmenorrhea, these are inflammatory in origin. This pain is inflammatory origin, and morphine has got no anti-inflammatory effect. If we give morphine, then this drug will relieve pain due to its analgesic effect. But as it has got no anti-inflammatory effect, so when the drug's effect will be withdrawn, again she or she will feel pain. So again he or she will use drug, and this time will use drug in higher dose. And again, pain will be relieved, but again, as it has got no anti-inflammatory effect, so again pain recurs. And in this way, a time will come when patient will develop tolerance. That's why in this situation, morphine should not be given. Rather, in this situation, drug of choice is NSAID, which has got anti-inflammatory effect. Now, regarding mechanism of action of morphine, one point, this drug binds with receptor and for drug receptor complex. Receptors are mu, mostly mu, then kappa, delta, sigma, these are all. And these receptor, as a result of formation of drug receptor complex, they decrease cyclic AMP and they modulate the ion channels. Modulate the cyclic by second messenger, then it modulates the cyclic AMP second messenger, decreases it and then modulates the ion channels. And there is increased conductance of the potassium and decrease entry, blocks the calcium channel, decrease entry of calcium. So intracellular potassium level will be increased and intracellular calcium level will be increased. Calcium level will be decreased. So hyperpolarization will occur. So the nerve becomes stabilized and there will be activity will be decreased and thus produces relieves pain. And also by promoting endogenous opioids like endorphin, dynorphin and enkephalin, they will produce analgesic effect and it stimulates the descending pain inhibitory pathway and inhibiting the pain neurotransmitter like substance P, glutamate, 5-HT, noradrenaline. All these factors leads to analgesic effect. Now, one of the indication was missing and that was shivering. In case of shivering, morphine, especially morphine-like drug is pethidine, synthetic drug pethidine is the drug of choice for shivering. So this is another indication for opioid drugs. Now, morphine and pethidine. Pethidine is a synthetic drug. It is there are some differences between morphine and pethidine. Morphine is a natural drug obtained from plant and pethidine is a synthetic drug produced in the laboratory. Morphine is highly powerful and pethidine is 10 times less powerful. Morphine is vagotonic and pethidine is vagolytic. Means morphine is vaga-like and pethidine is vagolytic, means atropine-like. So morphine causes pinpoint pupil, but atropine causes mydriasis. Morphine causes dilatation of constriction of the bronchus, but pethidine, as it has got atropine-like activity, may cause bronchodilation. But still, this drug should not be, pethidine should not be used in the treatment of in case of patient having pain with bronchial asthma or COPD. Now, morphine is spasmogenic. That's why in case of biliary colic or urinary colic, it should be avoided. But pethidine can be given because it has got an analgesic effect as well as it has got anti-spasmodic effect. So this drug can be given. And regarding obstetrical analgesics, pethidine, morphine is not cannot be used, but pethidine can be used in case of obstetrical analgesics. Exhausted labor, mother having exhausted labor, having pain, so it is unbearable for her. But in this situation, we cannot use morphine. To relieve pain, we can use pethidine. Why? Both the drugs, morphine and pethidine, can cross placental barrier. But in the placenta, there are enzymes which can destroy pethidine, but not morphine. So morphine will remain there and will produce harm to the fetus. But pethidine, it enters, but as it is metabolized by the placental enzyme, so will not do harm to the fetus. That's why, for obstetrical purpose, pethidine is preferred to morphine. This is a very important point, should be remembered. Now, morphine, now other differences, morphine, one is spasmogenic, one is spasmolytic. Morphine has got anti-tussive effect, but pethidine has got no anti-tussive effect. Morphine causes retention of urine, but pethidine cannot cause retention of urine. But both the drugs can produce addiction, have addiction liabilities. And more duration of action of morphine is longer, and that of pethidine a bit shorter. So these are the differences between morphine and pethidine. Now there is another drug is tramadol, and this is a synthetic drug. This drug is efficacy equivalent to that of pethidine. This drug can be, it also binds with mu receptor and produce analgesic effect. But this drug has got low addiction liabilities. This drug has got low constipation liabilities, but it has got more nausea and vomiting liabilities. This drug can be given orally because not undergo extensive first-pass metabolism. And this drug produces their effect by, it inhibits the reuptake of noradrenaline by the adrenergic nerve, and it also releases 5-HT from the nerve, and it may be responsible for its for analgesic effect. Now morphine and there are receptor antagonists. Morphine is an agonist, and there is partial agonist. There are pure agonist. Nalorphine is a partial agonist. Then buprenorphine is also a partial agonist. But naloxone, naltrexone, and nalmefene, they are pure agonists. They are pure agonists. Now, morphine, most important hazard of morphine is tolerance and dependence. The tolerance produces by morphine, this is due to pharmacodynamic tolerance. Tolerance may be pharmacodynamic, may be pharmacokinetic. Phenobarbital, this drug induces enzyme and increases its own metabolism, produces tolerance, and that is called pharmacokinetic tolerance or dispositional tolerance. But morphine, due to receptor desensitization, due to desensitization of the receptor, or due to download of the receptor, there is gradual diminution of response leading to tolerance, and this is pharmacodynamic tolerance. Now, in case of morphine addict, this drug, if it is suddenly withdrawn, then there will be withdrawal syndrome. With that there will be running nose, watering from the eye, coryza, severe abdominal cramp, diarrhea, urinary micturition, and hypothermia. All these factors will be all the symptoms will be occurred if we suddenly withdraws this drug. So the management of morphine addict should be gradually a drug should be withdrawn, and this drug will be replaced by a drug that belongs to that group having weaker activity, like methadone. This methadone can be given orally. It does not undergo hepatic first-pass metabolism. Plus, it has got longer duration of action. So, initially, morphine drug has to be reduced and methadone has to be added. Then, gradually, morphine dose reduces, and gradually, methadone dose of the methadone increases. And in this way, treatment should be continued, and ultimately, again, methadone should be gradually reduced, and then their propranolol, beta blocker, can be replaced. But the main thing is counseling, and main thing is psychological support and rehabilitation is the vital thing for the management of an addict. Now, this morphine relieves pain, and also there is another group, that is NSAID group, which we will discuss inshallah later on. But just I have to mention This group nowadays are quite adequately, extensively used to relieve pain. Because this drug, NSAID group, it has got some properties. That is, they will produce analgesic effect not by interacting with central nervous system, not by, they will not produce respiratory depression, they will not produce sedation, and they will not undergo hepatic fast pass metabolism. So these drugs can be given orally. And as morphine is a drug having addiction liabilities, depressed central nervous system, they have got opioid groups, they have got low therapeutic index. On the other hand, these drugs, NSAID group, have got a high therapeutic index. Now, regarding opioid groups, they affect central nervous system, they depress central nervous system, they produce respiratory depression, they produce tolerance and dependence. So this thing should be kept in mind, that if we get drug having producing analgesic effect, bypassing central nervous system, bypassing tolerance and dependence and respiratory depression, that drug should be preferred. That's why we nowadays we prefer ketorolac, or ketorolac is preferred, then diclofenac. These drugs are used because they will produce their analgesic effect by inhibiting prostaglandin synthesis, and they have got high therapeutic index. Now, another drug, paracetamol, is quite widely used for pain of body ache, pain of myalgia, pain of toothache. In this situation, we use paracetamol, and also this drug uses to relieve as an antipyretic. So paracetamol, you may be asked by what are the differences between paracetamol and morphine or pethidine. So you have to repeat these things again, because paracetamol is a drug which belongs to NSAID. In true sense, this drug is not a member of paracetamol, but in another sense, because its antipyretic effect. This paracetamol in periphery cannot block the synthesis of prostaglandin, or weakly block the synthesis of prostaglandin, but for its antipyretic effect, its central effect, it blocks prostaglandin synthesis, thereby it produces antipyretic effect. So paracetamol used for antipyretic purpose as well as for analgesic purpose. Somatic pain or pain of the body or pain of inflammatory origin. In this situation, paracetamol is the drug of choice, and paracetamol does not interfere respiration, does not interfere central nervous system, does not have addiction liabilities, does not induce sleep, but only it will produce analgesic effect. The somatic pain is relieved, and it has got antipyretic effect. So these differences, this can be asked by the examiners also. Now, the morphine, in case of head injury, morphine should not be given because of the reasons I mentioned earlier. Just I am repeating that it will worsen the situation, because it will inhibit respiratory center, so there will be accumulation of carbon dioxide, which will cause intracranial cerebral vasodilatation, then increased intracranial pressure, and also pupillary changes cannot be assessed because it remains in pinpoint form, and because of activity on spinal cord, there will be increased convulsion, and it produces vomiting. So all these factors leads to worsening of the patient. So this drug should be avoided during in case of head injury patients. And if a patient have got respiratory pain with respiratory problem, respiratory insufficiency, poor respiratory reserve, here morphine should not be given, because morphine, by stimulating vagus as well as by releasing histamine, it will aggravates respiratory difficulties, respiratory problem. And another indication is an indication of morphine opioids is shivering. In case of shivering, drug of choice is pethidine. Pethidine counters shivering, and this drug can be used. And addict has got skin, there is extensive itching because of release of histamine from the mast cell, and that is responsible for itching. And so the skin of the addict patient will be coarse, and temperature will be low. So and they have got blurring of vision, photophobia because of pinpoint people. So this drug, though it is a champion drug to relieve pain, it has got its use should be avoided as far as possible, and because of the risk of tolerance and dependence, because of the risk of addiction. Addiction is a global problem, and it is, we know, we discussed earlier that a state of periodic or chronic intoxication produced by repeated administration of a drug and is characterized by overpowering desire to procure the drug, intensive urge to procure the drug, tendency to increase the dose, then detrimental effect to individual himself and to the society, and then dependence, not only physical, psychological, but also physical. Physical dependence is more dangerous than psychological dependence, and detrimental effect to individual himself and to the society, both are dangerous, and withdrawal syndrome. So regarding addiction, we have to say that we have to say no. This is a very dangerous problem, a global problem. So we have to avoid. We have to this addiction should be. We have to say no. Again, we have to say no. Now this is about opioid analgesics. One thing, these drugs are a highly active drug, and it is action is receptor mediated, and its antidote is naloxone or naltrexone or nalmefene. So thank you for your patient hearing. Assalamu alaikum wa rahmatullah.